Hi everyone, and welcome to week 2 of the rolling teaching program for sickle cell disease. For those of you who don't know me, my name is Christopher Dean. I am the paediatric red cell nurse specialist here at ECLH, and I'm also the lead nurse for education and training for the Red Cell Network. Week 2's topic is about the complications that can arise in sickle cell disease. And before we begin, I just wanted to go over some learning objectives for this week. So we'd like the candidates to be able to gain an understanding of the common complications of sickle cell disease, which include vaso-occlusive crises, the acute chest syndrome, splenic sequestration, stroke in sickle cell disease, and fat emboli syndrome. And we'll be going over the treatment options available for these as well. Also, we'd like you to gain a knowledge of the warning signs to look out for to recognize these potential complications and any signs of deterioration.
So first off, we shall look at vaso-occlusive crises. So it's the most common reasons why our service users present to A&E. The symptoms of which is pain, fatigue, jaundice, shortness of breath, dizziness, headaches, and symptoms of headache. But does anyone actually know what it is, how it works, why these crises happen? Feel free to speak out if you want to chip in. That's right. I can. Oh, someone says. Yeah. Okay. Awesome. So I'll go through it with you guys. So if we think about what sickle cell actually is, I explained this in the last presentation, which you'll find on the website. So the red blood cells become, when they deoxygenate, the hemoglobin polymerizes, creating these long, hard rods, which distort the shape of the red blood cell into a sickle shape, like a C, or like the old style tools that farmers used to use to cut down wheat. Hence why it's got the name sickle. So when they go along, it irritates the blood vessels, which makes the body release selectin, which is also known as a sticky factor. And when that happens, you can see here in this little diagram, the red blood cells get caught up in the stickiness, the white blood cells, and also the platelets. So when that sort of happens, everything starts to become quite sticky. So in the end, more cells decide to come and join the party, get sticky, join in, block the vessel, and they start clustering or clumping. As more and more cells interact with these selectins, the cells get stuck together and to the vessel walls, and like I say, begin to cluster. And eventually, they end up causing blockages. So the clusters build up and become blockages, making it difficult for blood and also oxygen to flow normally. And the process is ongoing. So what can trigger a VOC? Does anyone actually know what can cause these clusterings to happen? So we know sometimes infection can cause it, stress as well, and trying to say to someone, try to manage your stress to prevent a sickle cell crisis can be quite tough, especially when we've just had a pandemic. These patients are trying to work, they're trying to live their best lives, and yeah, they can't really do that. Dehydration is a big one, because if they become dehydrated, the bloodstream becomes more viscous, and as we all know, it could increase hemoglobin due to concentration, and with more red blood cells and stickier bloods, then more clumping is going to happen. Cold, hot weather, so sudden weather changes cause issues. So for our patients who are going out in, probably not today's weather, because today is just unnaturally hot, I just can't handle it. But during winter, when our patients go out, they need to layer up. Because as we all know, when it's cold, vasoconstriction happens, making smaller blood vessels, meaning the clumping is going to happen quicker and easier. Sudden change in temperature as well. So I have patients who go back to, say, Nigeria for their summer holidays. So they go over there for 6 weeks and they go on a plane. And as soon as they get off the plane in Nigeria and it's 40-degree heat, they go straight into a crisis, which we can't really avoid. And sometimes we just don't know why it happens. You know, we can't identify a trigger. Say when someone comes into hospital, we always say to them, can you identify anything that's happened? Have you been ill recently? Have you been under a lot of stress? Have you been drinking enough? And they've been doing everything right. And we just can't figure out why it happened. So the treatments for that, so what they can do at home, depending on the patient, some patients can have opioids at home, some can't. Some trusts do community parentals, but that's practice is sort of going down at the moment. If our patients are needing more than paracetamol, ibuprofen, or naproxen and are starting using opioids a bit more, then they need to come in. They need to maximize their hydration, but sometimes they're in too much pain to be able to lift a cup to drink it. So they might need some IV fluids, bed rest, heat packs, you know, those little camping ones where they can crush it and use it, or a hot water bottle. Massage can be good. Some patients are very good at massaging their legs, like for example, if the crisis is happening there, because the crisis can happen anywhere in their body. Now, this came up as a suggestion, and some people say they do yoga to help. If it helps, great. And breathing exercises. We're very good at promoting how patients can manage their pain. Because the amount of analgesia we give, it's not necessarily going to get rid of the pain completely. And we can do some distraction techniques to help out with that. So hospital-wise, we can give stronger painkillers. We can give oral morphine, we give oxycodone, we have various different things we can use. We have patches, we give parentals, so subcut opioids. Usually morphine as a first line, but some patients have oxycodone. We did previously use dihydrocodone, not dihydrocodone. Sorry, that was a slip up. I don't know why I thought of that. We used to use it's got out of my head. I don't know. Diamorphine. That's the word. However, there is a national shortage of that, and when it's gone, it's gone. So some of our patients we haven't seen in a while, it's on their patient key record to have diamorphine, and we've had to transition them onto a different kind. So transitioning those patients to morphine is usually what happens, and that can be quite troublesome. We also give PCA, so patient-controlled analgesias. In the younger kids, we sometimes do NCAs, so nurse-controlled analgesia. And I can see, Jane, we used to use pethidine. Yeah, they used to be used. We can maximize the hydration, so we do oral or IV. We try not to do IV unless it's really necessary, because if we think about how damaged the blood vessels are for these patients, putting in a cannula or putting those needles to do blood tests will make the veins even harder to access. And that's not great for the patient, especially if they know that they can be difficult to cannulate. I always promote medical professionals to go to our patients and say, like, do you know which vein you like, which one works quite well, which one, so we don't have to do like 10 attempts. Regular monitoring, so we want to do all of their vital signs, we want to do their saturations in air, just because there's such a high risk of acute chest syndrome in our patients. Bed rest again. We might give a top-up transfusion, so the whole idea of giving a top-up transfusion is to help improve anemia, as well as trying to suppress down what their S percentage is, so how much sickle hemoglobin they have. However, top-up transfusions have their own risks. Our patients develop antibodies like nobody's business, and we're not sure why that happens. So it might get harder and harder to transfuse our patients. And if they are on a regular top-up transfusion program, we're worried about iron overload, and that means we're going to have to do some sort of chelation treatment. And we might also do red cell exchanges if it's a prolonged pain. And that is a lengthy procedure. It takes a couple of hours, 2 to 3 hours, where we remove several units of the patient's blood and transfuse in donated blood that doesn't have any sickle in it. So how to quickly just go on to this, how to prevent, minimize VOC. So keep hydrated. Patients should have water at all times. I am in constant battles with schools. Like I say, I'm the pediatric version, so I have many discussions with teachers saying you need to let them have a water bottle by them, and they need to be able to go to the toilet whenever they like. Continuing medication as prescribed, keep layered with clothing in cold weather, so wear skins sometimes. Swim in heated pools of swimming, because if they're in a non-heated pool and they're not constantly moving, they're going to get very cold and they're going to go into a crisis. And if they get out of the pool, they need to dry themselves off quite quickly. Limit alcohol intake because we know alcohol is a dehydration agent. Don't smoke because, again, that can clog up your arteries and cause all myriad of issues. And if traveling, this is a new one I learned of when I started this job. I didn't realize that not all airlines maintain the same cabin pressure. So our patients need to look into which airline they're using. They can't always necessarily use the cheapest option because it might not maintain the same cabin air pressure. So they usually have to fork out to go with the big names. Or if they choose to go with the budget airlines or ones who don't maintain the cabin pressure, they need to pay to rent an oxygen tank and take that on board of them.
How would you know? Yeah.
And we need to be informed if they're having any sleeping problems, so if they're having apneas or snoring, because again, lack of oxygen delivery to the body can lead to other issues.
Sometimes they have like medical fridges available, or you might have to take your own ice pack depending on what journey it is. Each individual airline will have.
So can I ask people to mute if I'm asking a question? Okay, so quickly just acute chest syndrome. So acute chest syndrome, anyone want to know what it is, how risky it is, how dangerous it is? So acute chest syndrome is respiratory symptoms and or fever in the presence of a new pulmonary infiltrate. So in itself, ACS is the leading cause of mortality in those with sickle cell disease. They become unwell quickly and deteriorate very quickly. And if we don't initiate treatment as soon as possible, they could pass away. So it results from the pooling of the sickle red blood cells in the lung tissue and may be precipitated by chest infection, fast embolism, or decreased respiratory excursion. It's not always possible or indeed necessary to differentiate ACS from an uncomplicated chest infection. And all patients with acute chest syndrome must be presumed to have an infection and should be treated with antibiotics for a community-acquired pneumonia. So I'm just letting someone in there. So we have antimicrobial guidelines, which you'll find in your own insight for those with red cell disorders in order to treat it. However, so the signs and symptoms, the reasons why we want to do oxygen saturations in air, in room air, is because if the saturations are more than 4% below the baseline, that's a real big indicator for acute chest syndrome. So if your patient's having oxygen, make sure you turn it off for 30 seconds, do their vital signs, and then pop it back on. Any changes in oxygen requirement, you should be talking to a doctor about so that they can come and review. New bibasal crackles, X-ray changes. So like we're saying, it's going to have some infiltrates in that X-ray. I'll show you a picture in a minute. And the following may also be present, but their absence does not include the diagnoses. So chest pain, so rib or pleuritic, back pain above the diaphragm, decreased respiratory excursion, decreased breath sounds, cough with an increased respiratory rate and shortness of breath, tachycardia and fever. So we have to be really careful and diagnose early for the most effective treatment to happen. So people who like a little diagram, you can see there all the sickle cells happening and the cycle that it takes to go through. Give that a second. All of these slides will be made available to you guys if you want to have them as well. Okay, so I'm just going to move on because I'm conscious of time. So this is an X-ray of one of my patients who has consented for us using these images. So as you can see, that's a bit of a dodgy chest X-ray. He's got loads of infiltrates. It looks hazy, it's patchy. And he had acute chest syndrome pretty badly. So the management of it, we need to do blood tests. And when you're doing a blood test for anyone with sickle, I would always suggest doing a cross match and order 8 to 12 units of blood as soon as possible. Alert blood bank, tell them that we need it. And as soon as possible, so if they can make it priority, because the main treatment for acute chest syndrome is to do red cell exchange. We'll do a chest X-ray to see what we're doing. The CTPA, if there is a high index or suspicion for a pulmonary embolism. We'll do a red cell exchange as soon as possible, and we need to transfer out if that service isn't available So say they go into a hospital like a DGH that don't deal with sickle on a sickle centre, they need to be sent elsewhere to be able to have an exchange as soon as possible. Ideally, we'd want it to be automated, but we will do a manual exchange if, say, there's a delay having a machine. It's going to take too long for them to get there to be able to have it, but it'll be too risky. And we might just do a manual. And for some reason, this always happens at like 2 in the morning. It's just cursing a night shift. IV maintenance fluids, IV antibiotics to cover for the chest infections, analgesia because it is quite painful. And sometimes we need to do aggressive respiratory support. So we might need to do CPAP, we might need to do intubation ventilation. However, we try to avoid that. And if we get acute chest syndrome early, we should be able to avoid that. Splenic sequestration, does anyone know what that is? It's quite common in children, unfortunately. So I'll quickly go over it. So splenic sequestration is the pooling of large amounts of blood in the spleen. So sometimes our patients present with abdominal distension, a massive spleen. You can palpate the spleen, and they become very anemic. And you're thinking, is this parvovirus that could cause an aplastic crises? Is this splenic sequestration? So it's most common in children with HBSS, so the most severe and most common form of sickle cell. They could also happen in patients with HBSC or those with HBF, so fetal hemoglobin, whose spleen have persisted into adulthood. So as we know, people with sickle, the spleen is largely not functional by the age of 4 or 5 due to the amount of sickling that's happening around the spleen. Hence, they're on their own prophylactic penicillin and are prone to bacterial infections and have to have extra vaccinations. So it's an medical emergency and requires urgent treatment. It is often associated with septicemia, most commonly due to pneumococcal type bacteria. There's a high mortality rate, usually from hypervolemia or severe anemia. And because of these issues, patients may go on to develop an acute chest syndrome and other sickle complications. So it's a terrible situation when they come in with splenic sequestration, and because they can't breathe properly because they're in pain and they develop sickling in their chest and potentially a chest infection as well. It's a vicious cycle. Signs and symptoms, pallor and lethargy. And remember, like I said, this happens in children mainly, or those over the age of 30. So in children, sometimes they can't communicate what's happening, how they feel, what's going on. So you need to use your non-verbal signs. They might present in shock and have sudden circulatory collapse. Abdominal distension with rapidly enlarging and painful spleen. Abdominal pain, which they might demonstrate by rising their legs up. I'm sure those of you who have had children might know the child that's like colicky or has some abdo pain, so just bring their legs right up. And they might have acute or worsening anemia with reticulocytosis, so the bone marrow is pushing out reticulocytes. As we know, are immature red blood cells because the body's trying to compensate and help. They might have a fever due to associated sepsis, and they have a greater drop in hemoglobin by 20 grams per litre. I'm going to show you an example now. So this is one of my patients who's consented. She's been in journals, she's been in everything. So she was 6 years old. She's got HBS beta 0 thalassemia. So again, quite a severe form. For her age, her spleen should average about 7.8 to 8.2 centimeters. And what was funny was that the week before, this family came over from Lebanon, I think it was, and they joined our clinic. They came under our service, and one of the first things we've taught them is about splenic sequestration, because how common it is in children. And a week later, the mum presented to A&E with her daughter, and the general pediatric team saw them, and the mum said, I think she's got splenic sequestration. And the doctor's like, really? And then they did all the scans, and lo and behold, she did. So I'm not sure how many people are au fait of looking at images, but say if you're looking at that diagram, that X-ray, not X-ray, sorry, the MRI that we did. On the left is the liver, and on the right, so our right but her left, that is the spleen that's going around that corner and all the way down. And it measured 16 centimeters, so hers doubled in size. Never seen a spleen that big. And thankfully, it did go down quite quickly after a blood transfusion, and it understandably we referred for a splenectomy because this could happen again. She's now a sassy preteen, so she's doing well. The management of a splenic sequestration, we'll just do blood tests to confirm the anemia. She should be, the patient should be in a high dependency bed. We need to support treatment of shock. We need to do immediate fluid resuscitation if required, so if they are in septic shock. But be mindful that this could dilute the blood further, so the hemoglobin might go down even further. And we need to alert blood bank, and we might need to use what we call flying squad blood, so generic blood to correct that anemia quite aggressively. We might also use blood to do the fluid resuscitation. So we'll do a top-up transfusion to correct the anemia, and it needs to be group rhesus and cow compatible. Broad spectrum antibiotics to cover pneumococcus and haemophilus. Again, there should be policies in place for antimicrobial guidelines to what should be used. And understandably, we need to educate our parents and teenagers how to feel for a spleen. So we know, generally speaking, the spleen's measured by one finger as 1 centimetre. So you might feel the tip of the spleen, you might feel 1 or 2 centimetres, but if you're feeling 3 or 4, that's when we start to think, get a bit edgy. And we'd say to come in to be reviewed and have some blood tests done. Briefly touch on stroke. So as we all know, stroke is a serious life-threatening medical condition that happens when the blood supply to part of the brain is cut off. So it's quite common in sickle cell disease, unfortunately. So we see ischemic stroke, we see intracerebral hemorrhage, subarachnoid hemorrhage, venous sinus thrombosis, headaches, and we see epilepsy as a result. So the different types of strokes, for those of you who don't know, so we have an ischemic stroke, so that's, you can see that there on the left that there's a clot that's blocking some vessels into the brain. Hemorrhagic stroke, so the vessel is actually broken open and blood is seeping out. And then a transient ischemic attack, another blockage there, which will correct. So I'm just going to talk about acute ischemic stroke because that's the most common. Like I say, it's most common in children in those over 30 years old. Often occurs in context or severe VOCs, ACSs, or other acute illnesses where fever and dehydration are a factor. May sometimes occur in otherwise well patient. May be silent and only picked up on neurocognitive assessment. So some of our patients, especially my teenagers, sometimes I talk to their school and they're not quite hitting their targets. It's something seems a little bit off in their learning. Maybe they've got like very mild learning difficulties and we're like, have they had some silent strokes? Have they had some silent infarcts? And we'll do an MRI head, and we can see it. And we're like, yeah, you've had some silent infarcts. Thankfully, it's only impacted your learning ability slightly and not being catastrophic and resulting in your death. The fact that the patient has sickle cell disease should not exclude any other causes for stroke. So be mindful that it might not be the sickle that's caused that stroke. Symptoms, very generalized, is limb weakness, paresthesia, so like pins and needles, fits, acute confusion, headaches, and before I brought that little image there saying act fast, so be mindful of face, arms, and speech. We need to do some scanning to make sure what's happening. They'll come in usually as a priority call, and the stroke team will be alerted that they're coming in with suspected stroke. If the patient's known to have sickle cell disease, the teams will speak together and the red cell team will be involved. The consultant usually comes in if it's out of hours. A negative scan at an early stage does not necessarily exclude that a brain infarction has happened. So there's a lot of clinical judgment in there. And as I said, urgent referrals to the stroke team and the red cell team. So I won't go into this in detail, but this is basically a little algorithm that we use here at UCLH. Depending on who's reviewing, we'll try to do a red cell exchange from our side. The stroke team will start advise on the thrombolysis pathway. So what we do, what we're doing. The patient might need to be transferred out if they've bled. So, for example, at UCLH, we can transfer out to the National Hospital for Neurology, which is part of UCLH anyway, but that's where the neurosurgeons live. We've had to do this recently with one of my teenagers who unfortunately didn't make it. So it's a real shock that it can happen. But in order to prevent this from happening, we do monitoring in childhood for what we call a transcranial Doppler. So it's performed yearly or 2 yearly, depending on what kind of sickle cell they have. Starts at the age of 2 until roughly 16 years of age. After 16, it's quite hard to penetrate the skull to get to the vessels that we need to check check what's going on. The whole idea of it is to check the velocities of the blood flow in the major vessels in the brain. If the blood velocities are too high, then we were worried that there's an increased risk of stroke and other things happening. So we need to think, do we need to do anything different with the management plan to help prevent the risk of stroke? Some of our patients go on to top-up transfusions, so regular top-up transfusions. Again, I've talked previously about the issues surrounding that. However, it's been proven to work and help reduce the amount of strokes that happen. Hydroxycarbamide as well, which is one of our disease-modifying therapies, that has been shown to help improve the risk of stroke, but again, not without its difficulties and side effects. Yeah, so talked about that. We might also start on red cell exchanges regularly. However, there is a long waiting list for the red cell exchanges all over the country. Not everywhere can do them. So patients might have to travel a long way to have them done. For example, I have someone who lives up in Norfolk and he comes to London. And it becomes troublesome as well when our teenagers go to university. So they might decide to stay around London for universities so they can have their exchanges still, or we might need to see if we can get them elsewhere closer to the university, but still a lot of travel for someone who's a student. If they start them in childhood or teenage years, then we'll carry on into adulthood as well when they transition into adult services. So this is a nice little picture. I think this is in Ghana, explaining what it looks like. You can see next to where the little girl's eyes are, there's a little transducer, and that's what we use to check the velocities. There's plugs into a computer. We have these little ones which run on Windows XP, so that goes to show how old they are. We did, like I said, we did them yearly, but we might do them after 6 months if we have like a semi sort of borderline one to see where we're at. And then briefly, fat emboli syndrome, very rare. It's undiagnosed. Sometimes it goes undiagnosed, unnoticed, and there's not really any sort of testing that can be done to prove the diagnosis. So sometimes it's based on clinical judgment. So it's a devastating complication of sickle cell disease resulting from bone marrow necrosis, and it's associated with high mortality rates. The bone marrow necrosis results in fat globules and hematopoietic tissue entering the venous circulation, and that emboli, the fat emboli, can embolize the lungs, leading to an acute chest syndrome. It can go to the brain, it can go everywhere. Survivors of the fat emboli syndrome often suffer with severe neurological sequelae, so they might, if they survive, they might have some neurological deficit. And the treatment of this is emergency red cell exchange. There's some areas of contention about whether we also do a PEX, so a plasma exchange, but the research isn't that, there isn't much research to say how beneficial that is. But red cell exchanges are shown to help. Okay, so that's the end of me rambling. If anyone has any questions, please just speak up. I don't mind. Also, if you don't want to mention it on here, you can always email me. My details can be passed around, I don't mind. But yeah, it's your opportunity now to ask some questions, and I'll try to answer as best as I can. Oh, Tom, you have your hand up?
Yeah, hi, Christopher. Thank you. That was really interesting. Can you tell us anything about any drugs that can be used if patients have repeated crises events at all, and how they work?
Yeah, sure, I can go through
Thank
that.
you.
So the different options that we have for crises, so vaso-occlusive crises, we ideally want our patients to be on hydroxycarbamide because it's proven to work. We ideally nowadays, we would like to get them on at 9 months of age, and that's disease-modifying therapy. It's classified as chemotherapy. I think it's cytotoxic. So how this works is it's been used in hematology cancer for ages as like a leukodepletion, so decreasing your white blood cells. So we thought, hang on a minute, that could work for us. So we started using it for that because decreased white blood cells decrease inflammatory response and should hopefully prevent crises. But then we also found that for some reason, and we don't know why this happens, hydroxycarbamide forces your bone marrow to create fetal hemoglobin, and fetal hemoglobin can't sickle. So those are the two, that drug, and those are the two main reasons why we use it. Some patients get on with it quite well. It can cause bone marrow suppression, so they need to be monitored. The drug dose is also titratable, so sometimes you're getting them on a baseline dose of 25 mg per kilo per day, but their bone marrow is like, you know what, can't take it. I'm dropping my platelets. I'm going to go neutropenic. But most of our patients can be weaned up, and we try to get them up to 35 mg per kilo per day. But if we reach a good therapeutic dose, then and it's working for them, then we don't rock the boat. That's working. Yeah. We've always got room to move.
Yeah.
And for those, so my teenagers, for example, when they go for their growth spurt, we need to assess what their weight is because we're dosing it on their weight. So that's one of the main ones. It does affect your fertility temporarily. So some patients don't like it, but we could stop it, and then we'll try to think of something else if you're trying to get pregnant. It can also cause hair thinning and skin pigmentation, which some patients don't like. Next one is top-up transfusions. So like I say, they can, over time, top-up transfusions can reduce the S percentage, but again, risk of antibodies, risk of having lack of available donors. For example, we have one chap who there's only, I think, 1 or 2 fresh units for him in the country.
Yeah, that can be really difficult when they've got lots of antibodies, especially when you say they're coming in for a crisis and it's an emergency and you need that exchange. But yeah, availability of blood could be really challenging in those patients.
Yeah. We also can put people on red cell exchanges, but again, like I say, UCLH, for example, we have capacity for 140 patients on the red cell exchange program, with a couple of beds spared for those who are pregnant, and we have a 24/7 service, but that isn't always available in all the trusts going around. So we get patients transferred in. He might need a space. Our transitioning patients that come from our hospitals that have had exchanges in childhood are coming, and we don't have space for them, so we have to do a bit of joint up care. And like it's similar to top-up transfusions. The whole point is to drop the rest percentage by removing, say, like 10 units of their blood, depending on their size, and replacing with donor blood that doesn't have sickle. But again, trying to get the right blood is tricky to get that many units. Long waiting list. It's not based on when you join that list, it's based on clinical need. Then this red cell exchanges have been quite transformative in quite a few of our patients. I'll say our patients in their 40s or 50s who have lived for many years without having access to different medical treatments because they weren't available. And they say it's changed their life, which is great. It's really great. So we sometimes do manual blood exchanges on the little ones.
Yeah.
And I mean, I don't know if anyone's ever done it, but it's time consuming. It's one syringe out, one syringe in, because you can't create too much fluid shift in their little bodies. And trying to have a cooperative 3 or 4-year-old for that whole process is tricky. I have got like anger issues of Peppa Pig now because of the amount of times I've had to watch Peppa Pig trying to do an exchange as a P's nurse. And the other new one, the latest new drug, first one in 20 years for sickle cell, is crises, which is also it's a p-selectin inhibitor. It's quite new. We're still rolling it out. We're still getting patients onto it, and it's proven to drop the amount of VOCs by 50% alongside hydroxycarbamide. But it's an IV infusion, so it's day 0, day 2, 2 weeks after day 0, and then it's every 4 weeks after that. And you have a little window of opportunity, so a few days either side is fine. So I hope that covers. We also do transplants as well. We've branching out more into doing transplants, but at the moment, it's open to full siblings being the donor, which isn't always possible, and the donor could always be a sickle cell trait. But we need to take to a panel to decide who goes for one, and we need to prove that nothing else is working, because it's not for the faint-hearted going through a whole bone marrow transplant with the conditioning and everything else. There is a trial coming in later this year for haplo transplants. We shall see how that goes. So haplo being a parent donating.
Okay, cool. Thanks, Chris. That was really clear. Thank you. That was really good.
Right. I've just got a question here. If hydroxy causes temporary infertility, then how safe is it in younger patients who are not in childbearing age yet? So all the research and data shows that it doesn't affect the developing reproductive system. It's just a temporary measure. And if we do offer sperm banking for adults who are starting on it, but everything will develop normally and fertility will still be as usual if we stop it. But again, that's one of the reasons why some parents decide not to do it. We are trying to say to parents, like, I understand, your child's not unwell, but let's prevent that from happening, because if they have all these VOCs, then think of like the late stage sort of issues that can happen, like the avascular necrosis, kidney damage, strokes. So that's quite often a discussion that we have, sort of saying, it's not to treat something, it's to prevent something. And the fertility is one of the things that makes the family hesitate. But we've got plenty of cases of people who have stopped taking it and fallen pregnant because they can't take it when they're pregnant. They can't take it when they're breastfeeding because it's expressed through the milk. And then they go back on it afterwards and it was good. And for those where we stop it during pregnancy, we try to get them on red cell exchanges because we need to condition that parent to be as healthy as they can before they go into labour. And quite often we say best to have a cesarean section like a week or two before your due date, so everything can be prepared and ready. Because sickling can happen in the placenta as well when you're pregnant, so it can cause all sorts of hypoxic damage to that unborn child. Oh. Is there any other questions briefly? Because we've got like 3 minutes left. It's already warned me we're at the end. But like I say, if no one has, you're more than welcome to email me. Sure, you will have the info Red Cell Network sort of email address, which had the invites on it. I have access to that inbox as well, and Amina will be able to share them with me and highlight them to me if needed. Okay. So, but I hope that was useful. And we're doing this again on Friday, so please share it with your friends. This one will be uploaded to our Red Cell Network website, which has other study days and other videos of me gas bagging on YouTube. So please have a look at that, share it around everyone. We're trying to get the message out to everywhere. And yeah, enjoy the rest of your day. Enjoy the heat if you can. I'm tempted to go on my balcony to finish my work day, but I don't know if it's going to happen. I don't know if I'm brave enough. But yeah, enjoy it all. I'll see you guys soon, hopefully.